basically this panel is really about tackling the challenges in emergency medicine as an underrepresented minority and or LGBT resident or student. Our panel is actually comprising of Nehal Naik. He is a MS4 at Virginia Commonwealth University, and now he's officially a physician at this point in time because he's already graduated. My name is, I know, right? My name is Nicole Nemore. I'm also an MS4 at Indiana University. Audrey Bickel is also an MS4 at Indiana University, and we both also graduated at this point in time. So we can officially call ourselves doctor. Dr. Moll is the program director at Virginia Commonwealth University, and he is going to be our advisor for this particular didactic. So thank you guys who did come. Okay, he will not say when he graduated, but he is a program director now. He's officially a boss. So thank you for being here, and thank you for helping us put on this didactic. We do appreciate it. Since there's only a few of us here today, I kind of hope we can kind of speed up this big presentation here. It's only 13 slides, and then we'll get to kind of the important stuff and kind of just talking to one another about, you know, things back and forth. We were hoping to do kind of an interactive poll. So if anyone has their phone or anything like that, you guys can go ahead and log on to poll, POLLEV.com/Nehal Naik. That's NEHALNAIK 652. So you can actually sign on to that, and you can actually, you know, do some of these polls along with us when we ask you guys specific questions during this actual presentation. So by all means, if anyone has their smartphone with them, please log on and, you know, answer some of these questions for us if you can, and we'll go through some things. So the structure of this hour, even though we're starting a little late, I apologize, is really just to talk about, you know, our experiences as being underrepresented minorities, going through the process of applying for emergency medicine, and even being medical students, and then, you know, any residents that happen to be in the crowd to kind of chime in and talk about their experiences as well, going through residency as an underrepresented minority or a member of the LGBT community. So we're hoping to actually break out into groups, but actually at this point in time, there's only a few of us, we won't do that. We'll just kind of talk one-on-one all together and kind of share our experiences. And, you know, anyone who's not a part of that group, even if you want to share your experience going through this process of interviewing and going through the process of, you know, being a physician and any kind of challenges that you might have had to tackle, you know, please share your experiences as well. You know, number one, I will say this is a safe space. There's only a few of us here. I promise you we are not judging you, okay? We are just newly minted physicians, so we're definitely not judging you at this point in time. Any advice you have, we will take, by all means. We will be respectful, and we hope that everyone else will be as well. Be open. You know, we'll share, you know, our experiences, and we hope that you share yours as well. So we'll definitely do a give and take, and, you know, we can all learn from each other. So what we face as trainees. So there was a study done in 2011 about family medicine residents. Unfortunately, there hasn't been anyone done on emergency medicine residents at this point in time, but the number of residents was 242, and it was a Canadian study. With that study, what they found was 44.7% of these residents reported mistreatment with the primary basis for mistreatment perceived to be gender, ethnicity, or culture. So they felt they were mistreated based on these things, whether it be gender, ethnicity, or culture. Sources of mistreatment included specialists or physicians. 77.1% of this mistreatment came from physicians, by also nurses, 54.3%, and then specialist residents, 45.7%, patients as well, 35.2%. So these sources of mistreatment came from supervisors, which were the specializing physicians, peers, the nurses, specialist residents, also your peers, and then also patients actually gave them mistreatment. We did not look into LGBT trainees during this time, just the underrepresented minorities. Only 54% knew process of addressing mistreatment or discrimination, or how to deal with this particular issue of being mistreated. So if anyone is actually logged onto our poll, the question that we have, seeing there's only a few of us, have you faced discrimination or treatment with the primary basis being gender or gender identity? Now, anyone who's not, you know, associated with this particular poll, and if you want to just speak into the microphone, by all means, please tell us, let us know what you think as well. We can keep this open as possible since there's only a few of us. I will, you know, I can actually say on my own personal basis, I have only had a few times where, based on gender, that I was mistreated. But I will say that some of those opportunities were done where I was at the VA, where it's usually mostly male-dominated, and they expect a lot of their physicians to be males. So that's one experience I can say, based on gender, where I was kind of mistreated a little bit. But once again, you know, we get through it, and I can talk about how I dealt with some of those experiences a little bit later on. Have you faced discrimination or mistreatment?
Quick question, sorry.
Please do, yeah.
I'm guessing the answer is no, because I don't see anybody in the back, but is this being recorded?
It is being recorded.
Okay, so you just all keep that in mind, please, because you may or may not want to identify yourselves. We've had a couple sensitive, you know, diversity topics that on ethics, things like that, that we encourage people, unless they wanted to, especially because you guys are probably a little bit more vulnerable state than myself. I make an ass of myself all the time, so I'm happy to continue to do so for a good cause.
Thank you, sir. Have you faced discrimination, mistreatment with the primary basis being race, ethnicity, or culture? You know, by all means, if anyone's on that poll, please go ahead and take the time to answer that question as well. I will defer to Dr. Moll, his expertise. If you don't want to identify yourself, we do respect that, by all means. We'll take a moment for the poll. And then moving on.
You have to make the poll active.
Sorry, everybody.
You hit the login page for the...
They have to activate it.
It's Nehal, so... Is that here?
We will double check that poll and make sure it gets active later on, okay? So for those of you who are actually watching the recording, we'll make sure it's active, and I'll have them keep it up for a little bit of a period of time. Maybe a couple months, we'll keep it active for everybody. All right. Have you faced discrimination or mistreatment with the primary basis being sexual orientation? And once again, we'll wait a little bit for that poll to be activated, or at least for people to get a chance to answer that poll question as they're following along on the recording. Okay, so moving to the meat of things, what steps can trainees take to deal with mistreatment, whether it be you're an underrepresented minority, or if you feel like you're being mistreated because of your gender identity, or also just a member of the LGBT community as well? The New England Journal of Medicine actually published an article on dealing with racist patients, specifically dealing with people who feel like they're in the underrepresented minority category, on how to deal with these particular patients. And there's a great also flow chart on how step by step to kind of go through this thing. So number one, especially with us being in emergency medicine, it comes down to this: is the patient stable or unstable? If they're unstable, don't worry about, you know, dealing with them. Take care of what you need to take care of. You know, take care of that patient. That's what we're here to do, and that's one of the great things about the profession that we've chosen. Now, stable, on the other hand. So if they're stable, then you have to deal with them, and then you have to make sure you can get them back to where they need to be, whether they need to be, you know, brought into the hospital or send them home on their merry way. Access decision-making capacity. So things of that. If a patient lacks, or, you know, if lacking, use persuasion or negotiation, number one. So we can negotiate with these patients to figure out, we can kind of work together to get them where they need to be, whether it be admission or back home to where they can be healed up safely at home. If the patient has capacity, determine the reason for why you're facing this discrimination from them. So number one, bigotry. You can discuss options with them, impact on that particular physician. So negotiate, offer transfer, accommodate, limit, unacceptable conduct. I think that's probably one of the biggest ones that I personally have had to use in the past. At some point in time, if you can't negotiate with this person, if you can't offer transfer or offer them someone else to work with, I mean, at some point in time, and also if you can't, you know, accommodate them as well, you can limit unacceptable conduct with that particular patient if you cannot move forward in their treatment. And then, of course, clinically and ethically appropriate reason, religion, culture, things of that nature, you can't accommodate. As far as religion and culture biases, or, you know, differences that you come in contact with the patient, at some point, you know, there's no need to talk about religion between you and that particular patient. If you can take religion off the table, then that's fine. If that patient would like for you to pray with them, sometimes you need to accommodate, whether you subscribe to that religion or not. I have plenty of times where I've prayed with a patient who needed prayer or needed to know that someone was there for them to at least have a moment of silence with them. That's something you can accommodate with a patient, okay? By all means, if anyone gets a chance, please look at this article from the New England Journal of Medicine. Just dealing with racist patients, like this is a phenomenal way to kind of go through and how to just step by step how to deal with these people and how to help them and also help yourself treat them, because that's at the end of the day is what we're trying to do.
So I would concur it's a very good article, and I would just like to point out it's very short. So none of us have time in emergency medicine, as much as we like to say, and no attention span. Literally, you can read this in probably 10 minutes.
And I think the flow chart that is in this article you can use for not just a racist patient, for any sort of patient, difficult patient. You can use the flow chart and, are they stable or not, go through it and figure out how to assess the situation, kind of diffuse the situation, figure out if you can reason with them and get them to accommodate you, if you can accommodate them, or if you need to transfer them to a different physician. So it's useful not just in racist patients, but any sort of difficult patient.
I have a question, and I might just be, anticipating the next slide. And if so, I learned yesterday that anticipating what you're going to do next is excellent. So first I was wondering your thoughts on the order of negotiate, offer, transfer, accommodate, and then limit unacceptable conduct, because I find it interesting that offering transfer before accommodating is listed.
Yeah.
And I was just wondering what your thoughts were on that.
I think, unfortunately, a lot of this stuff comes down to the patient and the situation. So I think in my personal opinion, it comes down to if this person just doesn't want to talk to you or deal with you at all, which can happen. I mean, there's no accommodating. There really isn't. Then you get to the point where if you can't even move forward with a history or you can't even figure out what's going on with this patient, we need to move on because there's other patients coming into the emergency room. As you're sitting here dealing with this difficult person, if you can't even get in a conversation, then you need to move on because the flow is backing up. I agree. So unfortunately, with the actual line on this, sometimes you have to go back and forth on it. If someone's cursing at you when you first walk in the room, you got to limit unacceptable activity. Say, hey, please, sir or ma'am, please don't use that language with me so we can move on, and you can move on to negotiating, and then going on to accommodate, and then going on to transfer. I mean, so it flows back and forth, and it really comes down to each individual patient.
And I would also add that, the transfer thing, I don't know if that's ever impractical going to happen. I mean, just because what are you going to say? I mean, the hospital down the street, I'm transferring, well, why are you transferring the patient? Okay, patient request, well, why did the patient request it? I mean, you can imagine how that conversation is going to go. And I mean, I suppose you could cover up or lie or what have you, which is not always the most ethical thing either. But I mean, I think it's good, I think that's put in there to respect the patient's autonomy to be able to request that. I just don't know how practical it is. Yeah.
I think the closest I've come as far as transferring patients go, or actually unfortunately, I guess for me, I've never had to transfer care of a patient. But I think I've actually physically seen one of my residents transfer a patient to another physician within our health system. I think that's as far as I've seen a transfer go for a difficult patient, if that helps clarify that.
And I'm not a trainee. It's, again, been quite a few years since I was a trainee, but the other thing we have to assess is the context of what we're doing. This is very different from having someone in family practice clinic or something like that. So we've got a second worry of there's currently an epidemic of violence against especially emergency medical treatment providers. Not just kind of physical violence, but verbal violence, emotional violence, things like that. And so that order does have to depend on what your current situation is. The limiting unacceptable conduct is, in my mind, always kind of the priority. If someone is spouting off this kind of language or behavior, my first thing that I do is cut that off at the knee. You will not speak to people like that. Otherwise, your treatment will be terminated here. But, I agree with Dr. Moll, the transfer doesn't really often become a viable option. Even if you're working in a place with multiple coverage, your partners may not necessarily have the bandwidth or really appreciate having to kind of take on another patient. So that's when you'll probably talk about kind of some of the mitigation strategies for this that you have to employ.
Excellent question. Thank you guys as well for your feedback. So what steps can a trainees take? So strategies to address discrimination towards trainees, which is a lot of us going into residency, and also the medical students as well. Assess illness acuity, of course. We always want to know, sick, not sick, stable, unstable. Cultivate a therapeutic alliance. I think really this is based on letting the patient know that you're there to help them. You're there to work with them, not just treating them, but we're there to work with them to get them better and get them out of the emergency room, because no one wants to be in the emergency room. And then depersonalizing whatever event occurred. Number big thing is keep in mind, all these people come in, they're in pain. It has nothing to do with you. It's not personal. They're in pain, or they're upset because they had to wait in the waiting room for a very long time because they're showing up for something maybe not so urgent. And sometimes they just need a vent. Giving them a moment to vent, letting them know it's not personal. You don't know them, they don't know you. And then more importantly, ensuring a safe learning environment for all trainees. That includes yourself as well. You know, make sure you keep yourself safe, number one. And then if you're a resident, make sure your medical students are safe. And then also make sure your peers and make sure your nursing staff, make sure they're safe. Because that's also one of our big jobs, is to make sure everyone around us is safe. So those are the big steps that we can take. On the poll as well, once it's activated, I apologize, but how many of you know how to report mistreatment, discrimination at your programs and or schools? Please, by all means, whenever you get a chance, go ahead and answer this poll question. I'll give a little pause for someone to go ahead and take the time to answer this poll question. So the answer options are yes, and I know how my program addresses this particular issue. Another answer is yes, only know how to report it, and then the last one is no as an option. So here's where we would actually break out into groups, and we would discuss a couple of things. You know, we would take an option. You can discuss having a difficult patient. You can discuss having a difficult coworker or peer. You can discuss having a difficult superior situation that may have faced you as an underrepresented minority or a member of the LGBT community. Instead of breaking out in groups, since there's only a few of us, I think what we'll do is I'll share a couple of my stories, and then I'll give Audrey the opportunity to share a couple of her stories, and then we can kind of talk a little bit about how we dealt facing or addressing these particular issues, and we'll answer a few of these questions. Question number one, what do you first do when you face this particular challenge? Question number two, how do you address it? Question number three, how do you cope personally with having to deal with this particular challenge? And then the last question, how can you grow or make your program grow from this particular challenge, which I think is probably the hardest question to answer at this point in time, particularly for some of us who are trainees. I'm going to give you guys two examples of, you know, going through life or even going through these past 4 years as an underrepresented minority, but also as a member of the LGBT community. So I know this is recording, you can't see me, but hi, my name is Nicole Nemore. I'm an African-American female. I'm a non-traditional student as well. So I'm actually going to piggyback onto a patient I talked about a little bit before. My last big rotation was my sub-I at the VA. It was an internal medicine sub-internship for me. And I did have a patient who was coming in, who was stable. He was on our floor. He was admitted to our floor for just a heart failure exacerbation. And he did not want to be treated by a female patient, period. So it had nothing to do with necessarily my skin or my sexual preference or sexual orientation. It really had to do with the fact that I was a female. He did not want to be treated by a female, which, you know, unfortunately, he grew up in a generation where most physicians were males and most nurses were female. So I was the nurse, and I needed to get the doctor to come help him and answer his questions for him. You know, as far as what was the first, you know, what do you do when you first face this challenge? So internally, you're like, oh, how dare you? I'm a fourth-year medical student, sir. I'm a great reporter and interpreter at this point in time. So you have that first step back moment. But what did I do? I walk around usually, you know, in the hospital with a smile on my face. So I'm happy I'm seeing patients and I'm not reading a book. So I'm usually pretty happy to be there when I'm there. I personally, for this particular patient, I really smiled and I actually accommodated him a little bit for his particular issue. So I just re-explained to him, I'm learning to be a practicing physician at this point in time. I'm a medical student in my 4th year, and I am learning from you, sir. So what I learned from you and what I learned from my group and what I come back and talk to you about for what I learned from my group and my team, I assure you is the correct medical knowledge that you need to know to help you get better. Actually, that actually worked with him. I only had a few times where I actually had to bring my resident along with me to address this particular issue. So how did I address it? Straight on. I actually just discussed it with him. I accommodated him by bringing my resident with me for the first 2 interactions that we had. From there on out, he was happy to just talk with me because I spent the most time with him. And then how did I personally cope with it at home? I laugh about it. A lot of these things I can laugh off, particularly with being, you know, a little bit of mistreatment, as long as it's not physical and as long as no one's being harmed. Some things, cope-wise, you have to go home and laugh about it. And remember, we got into this business to be servants. So unfortunately, when you're in the business of being a servant, because that's what we are, you're going to have to deal with difficult people. And that's kind of how I cope with it. How can I grow and how can I help my program grow from issues like this? I personally can grow from it by learning how to, number 3, cope with it. If I learn personally how to not take it necessarily so personal and not go home and, you know, cry and feel like I'm a horrible person for not being able to, you know, make everyone feel like everyone they meet is of equal ground, then I will never be able to move forward as a physician or as a human being. So my coping skills help me grow personally with this. Number 1, you can accommodate some of these people. Number 2, laugh a lot of it off. Now, how can I make my program grow from it? This is a little bit more difficult. I think this is a time where, fortunately for me, I was a sub-I. Therefore, there were 3rd-year medical students around me, so I could explain to them my process. That's how I helped my program grow in that particular instance. Now, the last thing I want to talk about had to do with the interview trail, and let me know if I'm going over, I apologize. So with IU School of Medicine at Indiana, we like to do practice sessions where we actually help some of the 4th-year medical students practice before we actually go into the residency realm and we're interviewing for our residency positions. During one of my practice rounds, one of my advisors actually mentioned to me, "Hey, Nicole, awesome, great job on the interview. I can see that you've done this several times." I'm old, which I have. I've interviewed several times. I can see that you've done this several times. One advice that I would give to you would be maybe not to talk about your wife. So, how did I deal with that particular issue? I'm fortunately blessed to be married to a wonderful radiology resident. And the way the interview trail is set up, we always have some kind of pre-interview dinner. And then there's always the actual interview itself. I don't know what your guys' experiences have been, but my experience has been it's nearly impossible not to discuss who you are and who the people are around you who are involved in your life. It's absolutely impossible to skip that. So that advice, I had 2 ways I could take that. I could listen to that advice, take my ring off and hide it, and not discuss it, and then once I got accepted to that program, surprise, I'm married, I'm a lesbian, I'm married to a physician as well. I could have done that, but I decided personally to ignore that. That's me going rogue, but I ignored that. I kept my ring on. During all my pre-interview dinners, I was honest about who I was honest about where I was coming from, and I was honest about my background. So how did I address it? I ignored that advice. I continued to be myself throughout the interview trail. And then, fortunately, I ended up at a great program, so hooray. So how do you cope with this particular kind of advice? I think this advice comes from a place of old values where, you know, it's something that there's an old feeling that you should hide who you are at some times. And I think that's up to you. That's a personal and person base, whether or not you want to hide who you are or not. I personally feel that with emergency medicine, they really want to know if you're okay to hang out with during these pre-interview dinners. They want to know if you're a cool person to have a beer with. That's the purpose. So if you're hiding something and holding back, you're not being yourself, which means you're probably a weird person to hang around. And that's kind of what I didn't want to deal with. So how did I grow from that experience, being myself? I got into a program that I knew wanted to be around me and was okay with accepting me for who I am, knowing that I didn't go into any of these situations lying in any of my interviews, holding back of who I was. How to make my program grow from that, I also shared that experience with third years who also asked me, how did I address this particular issue? Be yourself.
Can I just ask, you covered so much rich content, and not to interrupt, sorry, with your partner who's about ready to go and share experiences, definitely want to have time for that. But I just wonder what people thought, because I mean, one thing, accommodation is very different at different stages of the game. You know, when you were a medical student versus you're a resident versus an attending, accommodation becomes a very different thing. And then one of the things that I'm often asked as far as LGBT things is exactly that. I mean, you know, studies have shown, you know, medical students who are out go back in the closet when it comes to residency programs. Right. And in fact, I interviewed, I did like the speed mentoring thing yesterday. I just want to make sure this person's not here, so I'm not calling them out or making them feel bad. But you know, who was obviously, you know, stereotypically, let me put it that way, you know, LGBT and had, you know, male, 2 earrings in each ear. And I said, you know, you need to find a place where you're going to be comfortable, right, and being out with your husband. And I said, you know, you have to be aware of, you know, are you going to wear those earrings, you know, when you go interview and things like that. And I said, I personally recommend you do be yourself, right? They should want you for who you are. But then when I saw him later at the residency fair, he had butched up, taken the earrings out. And I'm like, well, that's your choice, but it saddens me. But I'm just curious if anybody else, what their thoughts are. Because I think that's something medical students really grapple with.
Go ahead.
So with the medical student side of things, you previously mentioned you don't like the word passing. I pass for a lot of things, and I'm grateful for it because at the end of the day, and people joke about this a lot, that the match is thousands of type A students who are putting their hands and their future into the hands of an algorithm. And of course I want to go to a program that accepts every aspect of who I am, but at the end of the day, I want to be accepted into a program. And so that's a very tricky line to navigate because yes, absolutely, I would love to, like the place where I would feel most comfortable learning, and you know, residency programs are all about family and really becoming a really solid unit. If I'm hiding part of myself, then it's withholding, there's stiffness, and I would want to avoid that. But at the same time,
You want a match?
I want a match.
I just turned it off.
Oh, hi, Cheryl Heron. Sorry, I ran in a little bit late. Good to see you. Good to see you. So I'm going to take it from two sides. So I'm also one of the assistant deans, a former program director, and have lived and breathed this work for a very long time, very committed to it. And what I would say is, and what I have done is, I'll start with students who come to me and say, what should I write in my MSPE? And I look at their CV, they've done incredible work on LGBT work, and it's all about, and I said, I just simply reflect and say, why would you leave that out if that is part of who you are? Because that is the biggest disservice is to yourself, frankly. And you will never, even if you get into the program, you will never be able to reconcile cheating yourself for who you are. Now, there is a gradation of maturity of life and years, meaning when you're older and you've lived longer and you haven't, like I took 6 years off from school, I lived life, I've done some things before I went to medical school, so I had a very different perspective of the world and what I felt I needed to succeed, right? And I tell students, if you go someplace and you aren't, you know, clear about your values and anchored in them and demonstrate them, you will never be a good doctor. I mean, not never, but it'll be more of a challenge for you to be a good physician. And so I can wax poetically about the life journey, you know, for me being African American women in Atlanta with braids, now dreads, definitely don't fit the profile. But over the years, I just absolutely refused to be anything other than myself. And because of that, I did pretty good in my life journey. I think I'm all right. and that leadership trajectory, which once we get to a critical mass of people who get there, is the light in the chink in the armor. And I'm sorry that happened yesterday, because that is crushing, you know, to see that we're still living in the reality of that world. But I would absolutely, while I understand, you know, you want to match and you want to do this, do you want to match and do this but can't do this because of not being able to be yourself?
And, I mean, and it's a different pathway, right? I mean, you had a double pathway in the sense you can't hide your skin color, right? You know, and you may want to try to, but you probably can't in any way, shape, or form. There are some people that can, you know, I mean, that, you know, that can quote unquote pass or whatever you want to call it. But I think LGBT is a little bit different thing, because often you can, you know, hide who you are, which hides a lot of who you are. Right. And having, you know, been through the days in the 80s and 90s where I was studying medicine, that no one was out, no one was out, no faculty were out, no, you know, students, whatever. And now, you know, I talk to medical students and stuff, and a lot of for them it's not a big deal, because they haven't had the horrible homophobia until 2016, unfortunately, because they, you know, really grew up in the sense of politics and such when things are getting more better, not worse. And now it's so important to be visible, because that's the one thing I've learned in my career, in my life, and that's why it makes me sad. So just sharing that.
I think, so I'll piggyback off of Nicole and share some of my interview experience. So I am gay, and I go to IU, and we kind of had this the Emergency Medicine Student Interest Group does this residency prep series, and we talked about interviewing, and one of the things that the program director was like, they're not supposed to ask if you're married. You know, that's not in any interview. They're not supposed to ask if you're married, if you have kids, or anything like that. Everyone does. Yes. Yeah. Everyone asks. I wouldn't say everyone. Not every single program I interviewed at, but a lot of programs ask. So, and he was even like, you know, you can withhold that information. You can tell him that you're gay. You can not tell him. It's completely up to you. So I went home and talked to my wife, and was like, you know, I don't really want to go to a program that's not going to accept me and you, and that we're going to be outcasts for the next 3 or 4 years. We'll both be miserable, and that's not going to be a good marriage. So we decided, and even my parents were concerned. They were like, you know, are you going to match? You know, do you think you should hide it? And so I was open.
That's why you should come to VCU.
Yeah. We're always
So I was open in my interviews, and I got asked 14 times what my husband does, which I kept track of because I thought it was really interesting. Everyone assumed, they see a ring on your finger, I guess I pass. People assumed that I was married to a man. So I think I made 14 people feel really uncomfortable when I said, well, actually my wife does computer programming, and everyone's face, you could tell that they were like, kind of shot themselves in the foot asking that question, and it was program directors that asked questions, and assistant program directors, and residents, and I feel like those are people that should know not
Program
to assume.
directors definitely should know better. I can see residents, but for a program director to do that, that's technically a match violation, and so, yeah, I'm sad to hear that.
We were sidebarring. Have you done this at Cord?
No.
You may want to just. Yeah. This needs to be done.
Yeah.
With bigger audience, no offense.
Yeah, we love you all, but we're the choir, right? We know.
I'm just wondering, how did you manage that with Grace? You know, because
So the first time I was like, I told myself I was going to be honest, and but it's awkward, right? I mean, it was
filed the aftermath with Grace,
right?
Because I think that I've made the decision that I will be out, and you know,
yeah.
But when you do face those kind of awkward situations,
So
and you've made somebody uncomfortable, how do you know?
Yeah, the first time it happened, it was at my second interview, and it was with the program director, and he was like, I'm sorry, I should not have assumed, I shouldn't have assumed, I apologize, and you could tell that he felt like an idiot, and so and I didn't really know what to do. It was awkward. But so I was like, I don't know if this is going to help me or hurt me, if he's going to feel like an idiot and because what he did was wrong, if he will rank me higher because he felt bad, or if this is totally going to hurt me in applying. So I kind of just tried to move on and said, this is what my wife does, and he apologized and was like, I shouldn't have assumed, and he, had a set of questions, so he just kind of moved on. But it was really awkward. But I'll be honest, it kind of became not a game, but it was a little, it's hurtful, but it was also kind of comical. I would call my wife and be like, well, I got 2 people ask me what my husband did today, or, because, on these interviews, it's 3 to 5 interviews that are 10 to 30 minutes long. So you interview with several people, and there were some programs that I never got asked that. They just asked me, if it came up, I would volunteer that I had a wife. But then there was other days where I would be asked twice what my husband did.
Right.
So if I can just want to address your point in particular, it's not your responsibility to make them feel comfortable.
Right.
Yeah.
So, Dr. And I've been on residency selection boards, been in the admissions committee at the medical school now for 3 years. They all know the rules. They know they're not supposed to ask that question. So if they get themselves in trouble with that question, that's entirely on them. And you have to answer however you are going to be able to feel comfortable and safe in this space. And leave it at that.
Yeah,
There's going to be an uncomfortable and awkward silence.
You don't always need to correct him. That's an individual situation. Because if I had a nickel for every time I would ask about my wife, I'd be actually pretty rich. But just for the nickel. But I think the flip side about that is, there's times I just not. I just kind of keep moving on, and it just isn't worth it. And it's hard because I'd like to think most people are open-minded, but I also know that people, even with good intentions, aren't necessarily very literate in this area. To Cheryl's point, her and I were just talking about it. I've not in my current shop and not at Emory, but I've been in residency discussions where they were like, oh, this student didn't share their sexuality, and so they were withholding from us. And I'm like, that is very inappropriate. On the flip side, the same group has said, this person kept talking about all the stuff they did in the LGBT community, and that's inappropriate. And I'm like, oh, wait a minute, which is it? Are you supposed to share or just share enough? That's showing so much bias, and you can't control what others do. You have to live in your own skin at the end of the day. And you have to find opportunity where you feel comfortable, which is why I strongly suggest that people, and I get, especially if you're a borderline candidate, maybe that you're really worried about matching at all, you're probably going to be pretty conservative, and I can't blame people for doing that. But you have to be yourself and live your lives, because ultimately that's what matters.
And so I will also turn it just a little bit, and I was saying that we're in a very interesting place in medicine, right? There is this attention to equity and inclusion, this attention to wellness and well-being, and short of maybe a few, I truly believe there is no malintent, because I can tell you that people are now in the inclusive part of families and a good working environment and making sure residents are well, and the fact that there is a vast knowledge and understanding of all things equity and inclusion, from people who are just coming out the womb to people who are been in the game for a very long time. And so our ability to understand this sort of train that people are on, hopefully with wanting to learn, and I think the embarrassment that might be felt was an educational lesson, even though that's not your job to teach people, but is it not, right? Maybe, right? Because people are on different pathways, and we're being peppered by the media and what's happening on the outside world, and being true to our core as emergency medicine physicians could help us feel, man, I really screwed that up. I've done it, and I'm thinking I'm pretty far along the trajectory of growth, but allowing for mistakes but learning from them is really what is going to help us all be better. And I agree, and I think in the bubble of wellness and well-being and family and normative, and husband and wives, that's just how people have been acculturated. And it is part of our role to understand that. I come from one of the most homophobic countries in the world. I'm Jamaican, right? And so I grew up and I'm like, wow, so I had to understand my reality of where I was born and what my country believes, and deconstruct that, but also understand that that's part of what I was surrounded with. So, being open to learning. That's why I'm really serious. You need to get this out to CORD so that they can appreciate and understand that we all have work to do and we can all help each other be better.
I mean, to that point, and I'm sorry, I really need to shut up, but I mean, I really think that, you know, getting out there, hearing, I mean, us hearing your stories is great because it helps us bond and share experiences. The straight white people need to hear the stories, and they need to hear your experiences, what you're going through. And so it's interesting. We've done obviously some research on this. You know, not so much the mistreatment aspect as you pointed out, but you know, when you look at all comers, especially in the current upcoming generation, there's only about 5% that are not incredibly supportive of equity for LGBT people. When you survey the residents, we did a national survey of residents, and there was 5% that said they don't think LGBT people should get the same health care as everybody else, and that's disappointing. But that's a monumental shift from what has been in the past. And so I think you should feel supported in your peer network, and you should feel supported even amongst program directors. We did a survey in 2014 among program directors, and 85% of them wanted more LGBT education. And so, you know, there's a need out there. So even, you know, who tend to be a generation above you, there's a tremendous level of support. So I suspect the person who asked your question truly was very embarrassed and probably learned a lesson. And so it's a good thing. And, you know, and that's happened to all of us. I mean, we matched 3 years ago a group of 9 men and 1 woman. And I'm like, oh, shit. You know, because that's not, you know, the kind of equitable, diverse, and inclusive group I want, right? And then so it turns out, I'm like, so I said to the chief resident at the time, I said, can you please reach out to her? I said, because I want her to feel happy and included, and like there's people here that are going to help her. And she's like, sure, you know, she's, you know, couples matched in medicine, and I'm going to reach out because I am, you know, coupled with a medicine resident. And so she called her up and she said, hey, this is so and so, and my husband's this, and what's your husband, you know, this and this and this. And she's like, it's my wife. And, you know, and she felt horrible, and I felt horrible because I'm like, I didn't know. And I told her to reach out. So, you know, but it was all good. It was all good. So anyway.
But again, the discomfort and being uncomfortable is just what it's going to have to be okay while we're in this space. I mean, and it shouldn't be that you're so uncomfortable that we shrink back and then stop talking, right? And I think the talking and the conversation has to continue, and we have to grow, and we have to all engage and that felt uncomfortable, but that's part of it, right? That's absolutely part of it. So we congratulate you both.
Thanks. I mean, I think for me, when the first time I got asked that question, in my mind I was like, should I just roll with it, or should I stay? And because it was the program director, and it was my second interview. And I was like, ugh, this is awful. So I made it uncomfortable, and I was just like, well, actually, it's my wife. And then, you know, hopefully, like you said, hopefully he did learn a lesson. And I would hope that any other LGBT person that followed me on the interview trail that interviewed at that program didn't go through that uncomfortable question. And
I would bet you earned a lot of respect.
And I had something to say about that too. Want to thank you for planting a seed, because I was on the opposite side of that when I was interviewing as a fourth-year med student. One of the assistant program directors of a program I really loved was sharing that he just got married and just moved, and I asked if his wife was in medicine too. And he said, no, it's actually my husband. So of course, it's a program I loved. I felt this big, and I went home and really thought about how deeply ingrained those types of assumptions I make are. I'm coming from like a Latino Catholic background. I have a lot of molds to break in my own mind. And something he doesn't know is that I went home, I talked to my husband about it, and we tried to really change our language. He's a marriage and family therapist, so when he talks to his clients, we both made it our goal to change our vocabulary. And then when I'm an intern now, so when we started interviewing people and I heard those assumptions being made, I went up at conference and I talked about it and just said, let's be really inclusive about our language, because I think that'll speak to everyone, not just the LGBT community, but to everyone, that we value diversity and inclusion. So I think maybe that assistant program director doesn't know what an impact he had on me, and then I made an impact on my program, and I'll continue to speak out. And so thank you for planting the seed, and hopefully you planted seeds with other people that you don't know grew into making big differences.
5 generations of physicians, right? Yeah. So we have got to remember, this is one of these, there are 5 generations of physicians, right? Which, let me say it again, 5, I mean, and then you're like, damn, from you know.
I'm trying to think which one I'm in.
Yeah, I know which one I'm in, Seth. No, in a good way. And I always remember that, or try to remember that in my brain when I'm trying to talk with physicians who are 80 and still working and their realities and what they've lived in and what their world is, and trying to say, okay, just remember the spectrum of people's experiences and exposures, and we're at a really good, critical point where you're like, wow, this is great, and we're moving, and we still need to move, but we're moving, right? So that's great.
I just want to jump back on, just one thing you said about you learning from experience as well. And I really, especially people who are listening to this conversation, like secondhand, I don't want you to feel like, oh, if I ask this question, I should have learned something from that. No, we learned too, because Audrey and I had to make a decision before we went on those interviews. How do I want to approach my life, and how do I want to put myself out there? So we had to learn as well to just go with it and make the decision to be ourselves. And I also think we have to learn as well to understand that we are representing the LGBT community when we go out into the public. We are representing African American females. We are representing Caucasian females. We are representing physicians when we go out into the community. You're constantly being scrutinized a little bit by everyone who comes in contact with you. You are representing these groups of people. So we too learn throughout every single one of these, confrontations or challenges that we face.
I'm just curious, has anybody had the experience of, for lack of a better term, outing yourself to a patient? How do you deal with that current circumstance? Because I think that can be very powerful. I'm just curious.
Yeah, well, I would say maybe 30% of my encounters begin with being misgendered. And it's because I wear men's shirts, sometimes men's ties. I haven't until very recently started putting nail polish on my fingers and makeup on my face, because I had not done that until maybe 3/4 of the way through my 3rd year of clinicals, because I just got exhausted by trying to navigate the misgendering and then keeping our relationship organic when the patient has clearly been made uncomfortable by my appearance. So, I guess I haven't still learned how to manage that with grace, and I haven't necessarily, I haven't kind of decided, how much of myself am I going to put into this, I guess my appearance at work, and then, I don't know, I haven't really learned any of that yet, so I guess that's why I'm here. So.
Anybody else? I'm just curious, because I think this was some of the most powerful moments of my career. Sorry, some of the most powerful moments of my career. I have somebody in their newly diagnosed HIV, and they come in, they've converted, and I can say, I have really good friends who have had this for years, and they're healthy and they're fine. Makes an amazing, powerful impact. When they've had situations where they've been sexually assaulted or mistreated, and intimate partner violence, and they've had a bad experience in ED, and I can say to them, I'm one of you, and I understand this, and we're going to make this better, and I'm going to respect your rights and things like that. And I don't tell everybody that, but there are certain select circumstances where I think it can be very powerful.
So I've had a few patients come in, and I'm active duty in the military, so these were kind of young kids who were, fortunately they joined after Don't Ask, Don't Tell was repealed, so they felt a little bit more comfortable, but you could tell that they were having this kind of awkward, and I just kind of said, these are some of the issues that we in the LGBT community can deal with, and you kind of I saw this change in their face, and just this kind of recognition, okay, I'm so, it's the going from the other to the same, going from that kind of still lingering fear that we have, that a lot of people in the LGBT community have about accessing health care, to at least identify
every minority,
someone,
I would say, every minority,
to having someone who can identify, okay, I recognize this person, now I can feel comfortable.
I've had experiences like that as well, where I've had LGBT patients who have come in some of them has nothing to do with the fact that they're LGBT, but you can tell that they're uncomfortable and feel out of place, and I've said, used we or us, and just kind of let them know that we're family, and that they don't have to hide or feel uncomfortable or awkward, or whoever the other person in the room is, you can tell it's okay that we're, they can be open, and it's not something they have to hide, and they can feel comfortable with me as their provider.
Especially when they're referring to their wife sitting next to them or their husband sitting next to them, and then that's usually when I'll come in and say, oh, well, awesome, my wife would have made me come to the ED too. I'm glad your wife brought you. So yeah, I definitely think there's always opportunity to out yourself, But at the same time, I think, it's pick and choose, because it should be a professional situation. You should guard yourself a little bit. But if you feel like this person needs that to feel comfortable, I'm more than happy to
There's no
share.
obligation by any way, shape, or form.
right.
Yeah, I'm just saying it's something that's a positive aspect of what sometimes is, can be personally negative. That's all.
To answer one of your questions, as far as how you feel you fit in, walking through clinicals and dealing with patients and coming into work. I mean, unfortunately, there's no straightforward playbook. We're actually all working on that right now with what we're doing and making our own personal decisions of how much we want to show who we are when it comes to being in the hospital. I think a lot of this is going to come down to your comfortability. You need to be comfortable, because if you're not comfortable walking to the hospital, seeing your patients, you're not going to be on your top game, right? And that's what you're really there to do. You're there to be the best physician you can be. So at the end of the day, do what makes you feel comfortable. If you feel comfortable wearing a shirt and a tie, if that makes you be the best physician you can be, feeling comfortable walking into the hospital, taking care of patients, then do that. Do what makes you feel like you're on your best game that day. If you feel more comfortable putting makeup on, feminine down a little bit, then do that. Do whatever you need to do to make sure you walk into that hospital and you're going to do the best that you can do for your patients. Because when you leave at the end of the day, if you did a great job, what do? You think about, okay, now I'm going to go have fun and take care of my own personal life. If you leave at the end of the day and you're thinking, oh, I messed up this or I messed up that or I wasn't on my top of my game, then you're constantly thinking about work. And that shouldn't be how you live your life. That's my one take on that. So, but by all means, get our contact information, ask us questions, and we'll tell you what we did and how we got through life and how we're going to get through life these next few years. I think we're about to get kicked out pretty soon, so thank you everybody for coming and sharing your stories.